Great. Now let's continue with circulation through organs. This is a quick section that we can just blast through. So the lung is the organ with the largest blood flow, which should be rather obvious because the pulmonary artery receives all of the blood that is pumped into the right ventricle. So everything that enters the right side of the heart must go from the right ventricle into the pulmonary artery and into the lungs. So they receive 100% of the cardiac output, unless of course we have some sort of defect in the septa or something like a patent ductus arteriosus. Next up is our liver. The liver receives an incredible amount of blood flow. Number one, it gets blood from the portal circulation, as well as number two, the hepatic artery. So it gets a dual blood supply, one from the hepatic portal vein, and then number two from the hepatic artery. This should key you into the fact that it is the organ that receives the largest percent or share of systemic cardiac output. Now, what about the kidneys? They actually receive the most blood flow per gram of tissue. This makes a lot of sense because all blood must be filtered. But the kidneys are incredibly small compared to the liver and the lungs. So that per gram of tissue, they get the most flow of blood. Now what about the myocardium itself? What do you need to know about that? The myocardium has an incredibly high oxygen requirement because it is constantly contracting and relaxing. The AVO2, or arteriovenous difference, which is represented by AVO delta, is the largest between the coronary arteries and the coronary sinus. CA for coronary artery, CS for coronary sinus. This is because the amount of oxygen extracted by the myocardium is 80% at baseline. So when the heart is increasing even faster, whether it's an increase in heart rate or an increase in contractility, you can only extract 20% more. That seems rather limited. So the supply is going to basically be stable, while the demand is going to increase. So how can we increase the supply of blood? The only way to do that is by coronary artery vasodilation. And this is a very important concept that you see will come into play when we talk about angina and myocardial infarctions in the cardiovascular pathology section. Now, what about the pressures in the heart? Let's discuss the normal expected pressures of the different chambers associated with the heart. First of all, how do we get these pressures to begin with? Well, if you're a cardiologist, you're going to stick a Swan-Ganz catheter into some vein of your patient. It can be the internal jugular vein, the IJV, the subclavian, or the femoral. It doesn't matter which one you want. They're not going to ask you this question on the exam. We just need to know that eventually we travel through some vein, through the right atrium, through the right ventricle, until we reach a small enough branch of the pulmonary artery that the capillary, the lead balloon part, gets stuck. So that is here. So again, we feed our Swan-Ganz catheter through some vein, and here is the internal jugular vein. It goes through the superior vena cava, the right atrium, through the right ventricle, into the pulmonary artery, and it gets stuck in a pulmonary artery branch. So when the catheter tip wedges into a vessel, it will completely block the flow forward. So essentially you create a column of stagnant blood. So whatever's in front of this, which we know is the pulmonary vasculature, and then the pulmonary vein, and then the left atrium, and then the left ventricle. So because blood is relatively stagnant and we have completely occluded flow, it is like we are extending one continuous column from this pulmonary artery branch all the way to the left atrium. Remember, there are no valves or anything between the pulmonary artery branches, the pulmonary vein, and the left atrium. So it's just like one continuous column because we have blocked flow. And this gives you a really cool ability to detect pressure behind and in front of this little catheter balloon tip. It has a pressure sensor on the tip of it. So now, let's discuss the pressures in the heart. Let's begin with the pulmonary capillary wedge pressure, because we just discussed how we wedge the tip of the Swan-Ganz catheter in a very small branch or capillary of the pulmonary artery. The expected range of the pulmonary capillary wedge pressure should be below 12. It directly reflects the pressure of the left atrium, because the pulmonary artery capillaries are considered a continuous vessel with the pulmonary vein, and the pulmonary veins are considered a continuous vessel with the left atrium. There are no valves or blockages between the two, or hopefully there's not. This is why using a pulmonary capillary wedge pressure is a great way to get a reading of the pressure in the left atrium. So as you can read here, the balloon is inflated in the pulmonary artery, and it is a static column of blood extending into the left atrium, which is an extension of the catheter. In the situation where there's no mitral stenosis, you can actually have left atrial pressure give you a good indication of left ventricular end diastolic pressure. That's because the left atrium is also contiguous with the left ventricle if the mitral valve is fully functional in diastole, when there should be an open communication between the two. If you were to have mitral stenosis, so a very stenotic fibrotic mitral valve sitting right here, and this is the left ventricle, there's buildup of pressure in the left atrium because this valve needs an extra oomph or an increased pressure behind it to push down on it and open it. This will augment your pulmonary capillary wedge pressure readings to the point where you cannot use it to estimate left ventricular end diastolic pressure, because there's no static column of blood extending from the left atrium all the way to the left ventricle due to this stenotic mitral valve. Now let's discuss the pulmonary artery. The pulmonary artery systolic pressure should be the same as the right ventricle, because the right ventricle is pumping blood directly into it during the right ventricular systolic period. This is assuming no pulmonary stenosis. This is the same concept. If the right ventricle must pump across the pulmonic valve into the pulmonary artery. If this valve is stenotic, you will have to have increased right ventricular pressures to push on this valve and open it. So in pulmonic stenosis, you would expect a difference between the pulmonary artery and the right ventricular pressure. Now, why is the diastolic pressure in the pulmonary artery greater than the diastolic pressure in the right ventricle if they are essentially one chamber when the pulmonic valve is normal and open? Well, the pulmonary artery and the vasculature in front of the pulmonary artery is very compliant. So when that very compliant pulmonary artery and pulmonary vasculature rebounds, the right ventricle has already sufficiently relaxed. This causes the pulmonic valve to shut and keep the diastolic pressure in the pulmonary artery higher than the pressure in the right ventricle during diastole. This is simple if you think about it in a sense that we want the pulmonic valve to be shut, and the pulmonic valve opens this direction. So the pulmonary artery must have a higher diastolic pressure to keep these valve leaflets pushed down to prevent any flow retrograde into the right ventricle. Pulmonary artery pressure is increased in left-sided heart failure, lung disease, and pulmonary vascular disease. All of these are related to hypoxic vasoconstriction. In left-sided heart failure, we have backup of pressures from the left side of the heart, causing hydrostatic pressure increases in the pulmonary vasculature, This causes transudation of fluid into the alveoli, causing hypoxic vasoconstriction. The same thing with lung disease. We obliterate our alveoli and eventually cause microcapillary damage, causing hypoxic vasoconstriction. With pulmonary vascular disease, such as Shirk-Strauss, you have obliteration of your pulmonary vasculature, further decreasing the ability to have blood delivered to the pulmonary vasculature, and this in itself will cause increased pressures of that pulmonary circulation because we are obliterating the number of vessels. And when you obliterate the number of vessels, you increase resistance and therefore cause an increase in pressure requirements to flow through those remaining vessels. Now what about the right ventricle? The right ventricle has a pressure around 25 millimeters of mercury in systole, because the pulmonary vasculature in front of it has so many vessels in parallel that the overall resistance is low. It doesn't have to reach a very high pressure. So in comparison with the left side of the heart that's pumping into the aorta, the pressures are like 1/5. This is directly due to 1/5 of the resistance in the systemic circulation is present in the pulmonary circulation. So therefore, because pressure equals flow times resistance, if you divide the resistance by 5, this automatically reduces the pressure you have to generate to pump into that vessel system by 5. Therefore, the systolic pressure in the right ventricle is 1/5 of 125, which makes sense because this is our left ventricular systolic pressure as opposed to the 25, which is our right ventricle systolic pressure. Now what about the right atrium? The right atrium is an extremely low pressure chamber. It directly connects with the venous system. A very, very low right atrial pressure means that you have very, very low intravascular volume, and that'll tell you about hypovolemia and dehydration. Remember, there are no valves between the systemic veins and the right atrium, so it is the lowest pressure chamber. The diastolic pressure in the right atrium usually equals the right ventricle when the tricuspid valve is open, because it's just one continuous extended chamber. So for example, what are some things that we could use this newly acquired or already reinforced knowledge about? So what are some conditions in which you would expect an increased right ventricular pressure? How about cardiac tamponade? Absolutely. So that's a little heart, and this is tamponade. So not only would the right atrial pressure be elevated, but because in cardiac tamponade there's accumulation of fluid or blood in the epicardial space surrounding the heart, all the pressures would equalize, because all the pressures would be dependent on the pressure of this fluid that is compressing the heart. So it is the one condition in which you would see an equilibrium of pressure between all 4 chambers. That is extremely high yield, and it will definitely be on your Step 1 exam.